From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University. It's become an annual end-of-the-year tradition of the last several years that my good friend and colleague Mike Gibson and I do a roundup of what we've learned over the course of the past year in cardiovascular medicine, particularly from the trials. We're going to go rapid fire through a number of topics. I'd like to cover ACS, CAD, heart failure, chronic kidney disease, and we're going to do it rapid fire. Sometimes we take a deep dive into the data. This time we're not. We're going to try at a higher level and try to give you Mike and I's views, concepts, if you will, that we think are driving these fields. Fortunately, our colleagues at Medscape are going to link all of the trials that we talk about so you can get the actual data to do a deeper dive yourself. So Mike and I will try to reflect, give you our opinion on how things in cardiovascular medicine, we see them as having shaped up in 2021. So with that, let me introduce my good friend and colleague, Dr. Mike Gibson. Mike is an interventional cardiologist at the Beth Israel Deaconess in Boston. He's a professor of medicine at the Harvard Medical School, and he is the director of the Baim Institute, an academic research organization. Mike, as always, thanks for joining us in this end-of-the-year show on Medscape Cardiology and the Heart.org.
Great to be back with you, Bob. And I do think people really want context, and they like it when we digest things and put things into context rather than the deep dive on details. So I look forward to our new format this year.
Mike, the first thing that I'll get you to comment on, wow, when I started preparing, and then when you and I were going back and forth over email the last couple of days, there was an amazing amount of new information that came out this year, despite the fact that none of us have, for the most part, been anywhere since 2019.
Well, I was surprised because you and I both know there are a lot of big trials out there that have really been slowed down due to COVID. And I was dumbfounded by how much information, how much data, how successful people were in completing high quality studies during the COVID era.
Yeah, I think that's a whole lesson to take away, isn't it, from the COVID era? I mean, remote data monitoring, remote visits, sending people home with devices so that you can collect material, sending physiologic material, sending people out to a subject's home to get blood tests and EKGs. Pretty remarkable, isn't it?
I hope it changes things. I hope we take some lessons to heart. I hope regulators realize that we can do a good job with remote monitoring and televisits. Obviously, you can't get an EKG or blood. But for so much of what we did, having people drive in, pay $40 to park, miss time off taking the relative in, I hope we can pivot away from that and do things simpler and more efficiently. And I hope this affects the cardiovascular trial world in a positive way.
Yeah, I mean, Mike, one of the things you and I will talk about today is that some of the questions that have been addressed are awesome questions, really important clinically, but maybe they were underpowered. Other trials in cardiovascular medicine are sufficiently powered to even detect relatively small differences. I'd like to see more of the latter and less of the former. And maybe if we can focus on what's really important, we can get big trials really done to answer some of these clinically relevant questions.
Yeah, I think, you and I lived through the mega trial world. Now I call it the giga trial world. When you have hundreds of thousands of patients enrolled in China in clustered designs, you are much more likely to get a definitive answer to the question. But as you say, Bob, we always in the back of our head have to say, what's the p-value here? It's the p-value statistically is significant, but the p-value for the patient, is it clinically meaningful? The p-value for the payer, is it cost effective? So it's a different approach. We'll answer the question definitively. We just have to put it into clinical context.
Perfect segue to the first grouping that I want to dive into, Mike, the area that you and I have spent a lot of time in the last 30 years, and that's acute coronary syndromes, coronary artery disease, and interventional cardiology, particularly PCI. We've been using dual antiplatelet therapy for a long time now, and we've been using a lot of different agents. There's been head-to-head comparisons. Boy, this past year has told me that there's still a lot of questions left And also, we've learned some new things. I mean, I'll just throw a couple things out there and get you to riff on them. First off, while we've always been talking about prolonged DAP, I mean, we had a trial of prolonged DAP. It really is looking in new stents with other therapies that shorter and shorter durations of DAP are possible, particularly in high bleeding risk patients, which is something that our friend Roxana Moran has been particularly interested in studied. Second, Mike, is this notion of going from dual antiplatelet therapy to single antiplatelet therapy. Oh, and guess what? That single antiplatelet therapy might not be aspirin. Third, de-escalation. This is something I've always sort of talked against because, hey, the studies did X with Clopidogrel, or the studies did Y with ticagrelor. Why would you switch back and forth? Well, now maybe we have some data around de-escalation. And then finally, a trial that we were involved with, Mike, aspirin. You were involved with the aspirin trial. How did we not know the right dose of aspirin? And after adaptable, do we still not know the right dose of aspirin? So let's start. Let's just tell us what you think about what happened in this world over the past year.
Well, the message is the world has changed. You know, when you and I were young interventional cardiologists, we had bare metal stents and we were putting people on dextran, Coumadin, Ticlid, Persantine, they were just waiting to bleed. And in fact, they did bleed. And in fact, bleeding was the biggest risk factor for stent thrombosis. We hadn't figured it out yet. I think ticlopidine really did, revolutionize the world when we switched over to that. And obviously some better drugs came along after that. But what's fascinating is we thought we needed a year. That was the intuition that after an ACS event, you would need a year. And obviously then people began to say, oh, no, we need more than a year. And we had, Pegasus and the DAP study to see if we need to extend beyond it. But Bob, I think the world has changed dramatically since those days. I mean, now we have thinner shunt stents. We have better biopolymers, or ones that are less inflammatory. We have much more aggressive lipid lowering. So we live in a world now of high dose atorva with combinations with things like ezetimibe. We have a fair amount of use, which is growing, of PCSK9 inhibition. We have a lot of other strategies, more aggressive blood pressure lowering, ACE inhibition, everything else. People are getting treated with much more evidence-based medicine, and event rates have really dropped. As we're planning current trials, we're starting to see that there aren't as many events out there as there used to be, and there aren't as many STEMIs. So, we always focused on efficacy. We always focused on number needed to treat and number needed to harm. But you know what I always say, Bob, it's also NNB, number needed to blame. Interventional cardiologists don't want to get blamed for bleeding events. And we do know that bleeding is associated with frailty. I'm not sure it's quite as dangerous in terms of a multivariate predictor of outcomes, but it may lead people to stop their drugs. And this has, of course, led to the effort that we're talking about to shorten and shorten and shorten the duration of antiplatelet therapy or dual antiplatelet therapy. We're now talking in some scenarios, particularly if someone's on an anticoagulant, to stopping at hospitalization. So less may be more. But here's my concern, Bob. I think we may have been cutting corners a bit on some of the early studies. They were awful small. They showed non-inferiority. I get nervous about small non-inferiority studies saying, looks like it's okay to shorten things. They had very broad, very, very broad confidence intervals. I am thrilled that we had two recent studies like Master DAP that was pretty big, thousands of patients. People have concluded, well, there you go. You can shorten DAP significantly without a penalty in terms of efficacy. But I want to highlight one limitation, Bob, in that these people had made it a month after their event, before their PCI, after their PCI rather, without having an ischemic event. It was cultivated for lower risk ischemic patients. And that makes me a little concerned about the conclusions we draw. Then there was a study that showed the opposite, STOP-DAP2, where, it didn't look like it was necessarily safe to stop early in a fairly well-powered study. So some different answers, but a lot of it driven by the risk of the patient, ischemic and bleeding risk. And then finally, Bob, on what's the right drug for, chronic therapy, we had the host exam study that showed Clopidogrel again, 25 years later, after Capri again showed Clopidogrel bested aspirin. So it's a question that needs to be readdressed in the modern era. Some of us are putting together a big PCORI grant to try and answer that. So as many questions as there are answers, maybe more questions, the world is changing.
Yeah, I love the way you summarize it, Mike. And I also like this notion of the individual risk. Is that one of my lessons that I learned from Bobby Ye's trial DAPT was that a lot of the events that occur in the stented patient is not due to the stented segment.
54% were
they're having events elsewhere. So, and that group got benefit from the dual strategy. So I think you're right. I think we're going to move to an era with more and more data that we're going to be able to do better risk prediction and really get to what we all want to get to, is what's the right combination of drugs for the right patient at the right time. What was
the right time, Bob, the right time. And that's
Exactly.
One of the big issues with risk prediction. You make a risk prediction at the beginning, at baseline, but if someone hasn't bled after 3 months, they're a different patient. They've declared that they tolerate the drug. I think we need an iterative approach to risk assessment. You wouldn't try to predict the weather a year from now. You would look, sequentially to modify your risk. I think we need to do more in terms of risk modification. Finally, Bob, I hate to say it, we're interventional cardiologists, but you know what? There's a patient attached to the stent, and I don't want us to see us lose the focus on secondary prevention, which I think we're a little bit at risk here with just this focus on treating the stent.
Yeah, I completely agree with that. As you know, I joke that I'm now a reformed interventionalist and have moved my practice to general cardiology. And it does force you to think a bit differently when you're seeing patients week after week in the clinic. It's been a good thing in my career over the course of the last few years. All right, Mike, I'm going to transition us now. Heart failure that I'm going to combine with CKD, and I think you know where I'm going. CKD has certainly emerged over this past year. It's always been important, but boy, have we learned a lot about CKD the last year. And the topic last year was SGLT2 inhibitors. I think the topic this year is SGLT2 inhibitors. Yes, there's some other drugs like from Figaro and Fidelity with other agents, but maybe let's have this conversation around SGLT2 inhibitors. Boy, some real success. We still have things to learn, but certainly now I think safe to say cornerstone therapy for heart failure.
Oh, absolutely. I mean, by the way, tough to be like the fourth or fifth kid on the block and show benefits on top of all those other drugs. Imagine if those other drugs had to show benefits on top of this class of drug. As Dr. Braunwald, my mentor and close friend, said, this class of drugs is the new statin. I also, I go to a lot of meetings these days with people in the renal area. And, unlike cardiology, they're often very pessimistic. They haven't had a win. They haven't had a win for their patients in a long time, and you're like, what works? What works for your patients? They're like, nothing works. This is so great to see something that actually may improve people for that axis, particularly where you have heart failure and kidney disease, or heart failure with diabetic kidney disease, or diabetic kidney disease, that whole axis. This is a big, big, big win for patients.
Yeah, I like the way you say it, Mike. And for me, chronic kidney disease, we've talked about it being a CKD risk factor. I mean, a CAD risk factor. It certainly is at this nexus, as you've said, of coronary disease, metabolic disease, heart failure. It's all intertwined. And I actually have applauded my heart failure colleagues coming out of HFSA this year. A lot of talk about, okay, let's forget about HFrEF, and just if they have clinical heart failure, here are the foundational drugs people need to be on. Now, I know that's a little bit of an oversimplification. There's certainly things we can learn about understanding the pathophysiology, but not a bad strategy to say that if your patient has signs, symptoms of clinical heart failure, these are the classes of drugs they ought to be on.
Bob, we have all grown up targeting one arrow, with drugs. There are so many arrows affecting the kidney and its health and the heart and its function. I think what we're starting to zero in is something that you and I probably both intuitively knew, that low starting doses of multiple drugs affecting multiple pathways might be the right starting point. And then, looking at, some of the different parameters, then escalating those. I was really scared the idea of starting 4 or 5 drugs at once in a heart failure patient, but I've circled around to philosophically and pathophysiologically that that's probably the right strategy. Let's hit all the arrows and then escalate as appropriate.
Yeah, and what it also brings in for me, Mike, is that you need to have a team help you do that, because you have to have close follow-up with the patients. People have to call the patients. People have to, be on the patient portals with the patient. To your point, if I'm going to start you on 3, 4, 5 new drugs, I've got to take some responsibility for my team being able to help you manage that.
And Bob, can I throw in a good word for another class, the GLP-1s?
Yes.
I personally, I think this class of drugs could totally revolutionize coronary artery disease. I mean, we're talking about, with a year of therapy with this drug, people losing 5 inches off their weight and losing on average 30 to 40 pounds, bringing their BMI down significantly. I think we have to be honest. A lot of heart disease is a disease of lifestyle. We have a diabetes epidemic. I think in the future, moving forward, I think this is going to be a critical class of drugs as part of not primary, maybe even moving into primordial prevention to really prevent the epidemic that we have.
Yeah, we have seen some trials this past year with the injectable GLP inhibitors that has been, I think, extraordinary. I mean, the amount of weight loss, as you said, is not what we had come to expect in metabolic obesity. I mean, in medical obesity management, the 5% body weight. We're talking like big shifts of weight, and yes. With better control of diabetes, with better lipid control, and really
lower blood pressure,
better blood pressure control. No, Mike, I agree with you. And I think the data is pretty compelling. Now we're going to need longer outcome data, et cetera. I don't think any of us would shy away from that, but I'm with you. This is an important class of drugs. Thanks for bringing it up. Let's shift gears again, Mike, into an area that you and I have spent a lot of our professional life, interventional cardiology and cardiac surgery. One of the things for me this past year is I've loved every big meeting, seeing at least 1 or 2 trials from our surgical colleagues asking really important questions about the technical stuff that they do. Let's talk just quickly about the left atrial appendage occlusion trial. Wow. That was a clever design, well powered. You want to talk about that for a minute?
Yeah, I mean, closing off that left atrial appendage at the time of surgery reduced your risk of embolic events by a third, as I recall. I think it is important. I think, hopefully, I think it probably should change practice, but then it brings up the question of, left atrial appendage closure percutaneously. I don't think the results can be translated 1-to-1 to the percutaneous approach by any means. It certainly philosophically and pathophysiologically indicates that there's a there in terms of preventing embolic events. I think we still have some limitations with where we're at with those devices. There is still a risk of device-related thrombosis, clot forming on the devices in about 3%. There's variable rates of leak around the device where, in maybe 5-10%, there's a leak where clot could go out. There's a lot of evolution in this class of devices rapidly. But I hope our device colleagues will embrace the idea of combining some of these devices, which are prothrombotic, which have surface activation of the clotting system, with some of our newer drugs. And particularly, Bob, I'm thinking about the factor 11 inhibitors, which do a great job at contact activation. Precisely this scenario where, you activate the clotting system with contact with a device like this. I'm hoping we see a marriage. I'm pushing the manufacturers to marry some of the very good devices with some of the newer drugs coming along, and I hope we can make some advances there.
Yeah, this will be a topic you and I can riff on next year, because you and I are both involved with factor 11 inhibitor trials, and I think that is a promising class of anticoagulants. And maybe we can give people an update next year, Mike, when we get together. Another great trial that the surgeons conquered or attempted was the what do you do when you're repairing the mitral valve when you have concomitant TR? I mean, that's an important clinical question, right? Do you assume that as you lower left atrial pressures and lower pulmonary artery pressures, that's going to translate ultimately into less TR? Or do you say structurally that valve has been damaged and we're going to have to, cinch it up a bit and put in a ring, et cetera? They did a randomized comparison. What do you think of that one?
Yeah, I applaud our surgical colleagues for the rigor with which they're doing these things. By the way, Bob, yesterday a statement came out in circulation from the AHA on, surgical trials and the methodology to do these trials. And there's been tremendous advances. But you're right, Bob. I mean, once the horse is out of the barn, you may need to do more than just fix the one valve.
Yeah, and I again applaud my surgical colleagues. This one done through the CT Surgical Network, through the NHLBI. Just the fact that they're willing to tackle some important questions like this. I saw the CERC paper as well. Yeah, really, really important statement. And kudos to our surgical and medical colleagues who are working together in that network. FAME3. My colleague here, Chief Cardiology at the Palo Alto VA, Bill Ferrin, really worked hard on this one and trying to understand if you really do complete revascularization using FFR guiding versus surgery, bypass surgery, what will the outcomes be? Well, the surgeons won on this one, didn't they, with CABG with advanced disease?
Yeah, I mean, I love Bill. I think he set up a high bar for himself, to beat surgery in complex disease. I don't know that we're there. I think surgery still wins, but I don't know that that's necessarily a bad rap on the technology for the less severe lesions. So I hope people don't take away, and sadly, I think some people took away the message that FFR is not helpful. I don't believe that. I do think in a less severe range, it is very helpful. But I think there's been a tremendous advance that I'm very excited about, and that is the computerized assessment of FFR based on angiographic images. And, Bob, for 35 years now, I've run an angiographic core lab, and, we've been analyzing arteries and analyzing their volume, in multiple dimensions. Of course, I invented the frame count, and we know how long a time it took up to fill that volume. So knowing volume and time, we have flow. And knowing flow and knowing the geometry, now there's really great computer fluid dynamic modeling software that looks at, resistance and does FFR in the lab from the angiogram. And what we're seeing are a series of studies showing that, like, the pressure wire, it can tell you you don't need to intervene on this lesion, but I always see it in the LAD. It may not look that tight, but it's longer. It's a long lesion, and you really should intervene on that one. So it's inexpensive. You won't have to put a wire in. No complications, no thrombotic complications, dissections. I think it could really change cath lab management. So don't give up on FFR.
No, I'm not giving up on it at all. I think that Bill has done us a real service of being able to think through the issues associated with maybe when you use FFR, when it provides the most incremental information. And like you, I liked the secondary analysis of FAME3, where they showed that there really is a gradation of benefit of surgery over percutaneous revascularization based on the syntax score. And again, it gets to our earlier conversation, Mike, of trying to find the right approach for the right patient at the right time. And using our tools that we have available, in this case, physiologic flow, can be an important way to help clinicians and patients have informed decision-making.
Absolutely. But me, there's a lot going on beyond the stenosis down in the microvasculature. And Bill and his team and you guys at Stanford are doing a great job looking at IMR, looking at microvascular resistance. And, that offers the hope also of really risk stratifying. And also during a STEMI, IMR is now being used to say, do I need to give something down in the microvasculature, one for the road for a lytic or 2B3 inhibitor or vasodilator, or am I good to go? So it's starting to creep into trials, and someday it may be part of our decision-making armamentarium.
Well, there's a whole other conversation we could have about the adjunct of medical therapy to, for example, primary PCI. It's more than just getting in there, opening it up and leaving. There may be groups of patients, certainly the shock patient is at the extreme, but as you point out, there's gradations of abnormal microvascular flow. You've shown this with the blush, that we really need to think about what should be the additional therapeutic approach.
And I got to emphasize it again, the LAD and the right coronary artery are two different animals. The LAD feeds a thick-walled ventricle. It's longer. There's a greater amount of myocardium at risk, and you get edema, lots of edema in that LAD territory. It behaves totally differently than a right, which is a larger, wider vessel, more clot, shorter, feeds into a low-pressure system. Probably going to need very different strategies of how to manage all this.
Well, Mike, we, over the last almost half hour, have covered an amazing amount of topics, and I still on my list have another dozen that I'd love to chat with you about. And I know that you and I have gone back and forth with all the trials. This has been a fantastic conversation. I hope people enjoy it. Mike, I hope you're going to stick around when you and I do our second segment at the end of the year, trying to get into some of the big public health issues, including the trials for in the COVID population. So thanks to our listeners for joining in. Thanks to my good friend Mike Gibson from Boston to have this conversation with me. And do join us on part 2 of what went on in cardiology in 2021. Thanks, Mike.
Thanks, Bob. I think we need a semi-annual review now.